Thank you, Mr. Chairman, and thank you to our panel. Dr. Holtz-Eakin, I have a question for you that is North Carolina specific. I'm very concerned with the number. I think with this proposed rule has a potential of affecting over 500,000 of my seniors. Do you know how many of those health care plans, I mean, in your numbers and in your research, do you know how many plans will be eliminated as a result of this in North Carolina?
We have an estimate that we'd be happy to get to you. When we did our analysis, we found out the number of beneficiaries in North Carolina. We then looked at the plans in North Carolina, and especially the large plans. We could identify those that had preferred pharmacy networks that would be eliminated, or other plans that would be eliminated, and we can get that to you.
Great, thank you. I'd appreciate that. You know, back in, there was a Milliman study done, a survey analysis in January 2014, CMS Medicare Part D proposed rule found that approximately 12.9 million Medicare Part D beneficiaries currently enrolled in preferred pharmacy PDPs may experience material premiums and cost-sharing increases in 2015 as a result, on average because of the proposed rule. Do you think this is right, that 12.9 million seniors will be affected this way? What are your thoughts on that?
It doesn't surprise me. I don't know if the precise estimate's the right one, but if you change the terms the way the rule proposes, there's not really anything known as a preferred pharmacy anymore.
Yeah.
So a plan can't go to pharmacy.
Pretty much just goes to, yeah.
Right, and so they can't cut as good a deal. The cost sharing will go away, and the prices, the net price to consumers will go up. Which is,
you know, exactly what, you know, I'm hearing today as we're, you know, doing the subcommittee hearing is there are two, you know, trains of thought that somehow we're going to be saving money, and yet it's contradicting each other, that by doing this we're actually going to be saving money, and yet we keep seeing that it's actually not going to be the case.
Yeah. I would just say to the committee, I mean, you know, this issue has these two sides, which is you want to be able to take terms of a contract to another pharmacy if you can. Wouldn't that be great? But can you cut a deal with as good of terms, and how does that balance out? There's been a lot of work done by the Federal Trade Commission, whose sole mandate is to identify pro-consumer aspects of competition, and they have found these preferred networks are very effective in helping beneficiaries and consumers, and I think the committee should look at it, and I think CMS should look at that work.
Thank you. Mr. Schmidt, I just, you know, in my years as a nurse, certainly one of those groups of patients that I have had the honor of taking care of and come to know, and their families come to know, are our HIV and AIDS patients. So first of all, I just want to thank you for all of the work that the institution is doing, because you are a vital voice in how much treatment has advanced for our AIDS patients. And I just want to ask your opinion, with the provisions that are being put forward in this proposed rule, is this not going to have a negative effect on our Medicare Part D patients who especially are receiving AIDS treatments?
Yeah, well, right now they're not proposing to eliminate, you know, access to antiretrovirals. But as I mentioned in our testimony, we're just concerned we could be next. And you know, the criteria that they came up with, you know, was very arbitrary. The 7 days, you know, initiate medication. You know, that will result in hospitalization or disability for a typical patient. They're not looking at a Medicare patient. Yeah, we are very concerned, and for the future and the harm that it could have to patients. But most immediately, it would have harm to those who need immunosuppressants and antidepressants, and in the future, antipsychotics. And as I said in my testimony, a lot of people with HIV also have mental health issues.
Yes.
And so, you know, around 50%. So we're very concerned about access for medications for them. And then my organization also advocates for people with hepatitis who undergo liver transplants, and they need immunosuppressants as well.
Absolutely. Thank you. And Mr. Baker, I just have a quick question for you. You know, the proposed rule changes, CMS actually pointed out that, you know, there was in this discussion that has already gone forward, and hopefully we're going to be able to have enough time for future discussion. Although I think that time is falling short. You know, the safeguards that are in place, do you feel that these patients are being safeguarded enough? And you know, as we have discussed, you know, the idea that we're actually saving money. I mean, you know, some of CMS's own findings are showing that this is not the case. You know, what do you say to that? And I'll just make one point that CMS put forward April 2013. It basically pointed out, it said negotiated pricing for the top 25 brands and 25 generics in Part D program at a preferred retail pharmacy is lower than a non-preferred network pharmacy. How do you justify the position that we're actually going to be saving money when we're already doing that, but by making these, you know, this proposed rule change that we'll end up saving more money?
I think, you know, there are projections and on both sides of the ledger, as it were, from various actuaries. I mean, we certainly think that given the track record that Part D has had thus far and the stewardship that CMS has been engaged in, that the proposal will lead to lower costs not only for consumers but also for the program itself. And so I think, and that's because of the any willing provider that has been in the pharmacy network overall. We're thinking that same will happen in the preferred network.
Mm-hmm. So we're projecting that, but we aren't seeing those results. So
well, there's a lot.
Thank you, and I apologize, Mr. Chairman. I've gone over.
Chair, thanks, gentlemen.